Welcome students to our new YouTube channel Pharma Extech, the division of excellence. So this is Sunday blockbuster series. So on this Sunday we will see the most important chapter from cardiovascular system, and this chapter is most important for GPAT aspirants and also MST CET aspirants. So the topic name is drug used to treat chronic heart failure or the drugs acting on chronic heart failure, and this chronic heart failure is also known as congestive heart failure. So this chronic heart failure is a condition in which the heart is unable to pump sufficient blood to meet the demand of body during rest or exercise, and this chronic heart failure is caused by the weakness of myocardial muscles and also the biochemical defects in that ineffective conversion of ATP and creatinine phosphate, and also atherosclerotic heart disease. So these are the causes of chronic heart failures, like weakness of myocardial muscles and biochemical defects in that ineffective conversion of ATP and creatinine phosphate, and also atherosclerotic heart disease. So next we see the drugs used to treat this chronic heart failure, and there are three types of classes in that: the vasodilators, diuretics and inotropic agents. So let's first see the vasodilators. In that, the AC inhibitors, and the example of AC inhibitors are captopril, enalapril, fosinopril, lisinopril, quinapril, and also hydralazine, isosorbide, minoxidil, sodium nitroprusside. So the AC inhibitors ends with pril. So all the drugs that ends with pril, they are AC inhibitors. So the next one is diuretics, and the example of diuretics are bumetanide, furosemide, hydrochlorothiazide and metolazone. So these are the diuretics drugs used to treat chronic heart failure. So the third one is inotropic agents, and the examples of inotropic agents are cardiac glycosides, in that digitoxin, digoxin, and this digoxin has hypokalemia as a side effects, and also beta adrenergic agonists like dobutamine and also phosphodiesterase 3 inhibitors, amrinone and milrinone. So these are inotropic agents. So next we see the inotropic agents in detail. So an inotrope is an agent that alters the force or energy of the muscle contractions. The positive inotropic agents increases the myocardial contractility, and they are used to support cardiac function in conditions such as decompensated congestive heart failure, and also in cardiogenic shock, septic shock, myocardial infarction and also cardiomyopathy, etc. So next we see the cardiac glycosides and their examples. So in that, cardiac glycosides are digoxin and digitoxin. They are inotropic agents. Then the second one is catecholamines, and the examples are dopamine, dobutamine, epinephrine. The epinephrine is also known as adrenaline, and also isoprenaline. This isoprenaline is also known as isoproterenol. And last one is norepinephrine, is also known as noradrenaline. So the third one is phosphodiesterase inhibitors, and the examples are milrinone, amrinone and theophylline. So the next we see the negative inotropic agents decreases myocardial contractility, and they are used to decrease the cardiac workload in conditions such as angina, while negative inotropism may precipitate or exacerbate the heart failure. And certain beta blockers, and the examples are carvedilol, bisoprolol and metoprolol. So the beta blockers examples are carvedilol, bisoprolol and metoprolol. they have been shown to reduce the morbidity and mortality in the congestive heart failure. So next, these examples are beta blockers. In that, first one is calcium channel blockers. They are diletazem and verapamil. So these are calcium channel blockers. So the second one is class first A antiarrhythmics, and the examples are quinidine, procainamide and disopyramide. So the third one is class first B phenytoin. In that, the example is mexiletine. So the fourth one is class first C antiarrhythmics, and the example is flecainamide, that means flecainide. So these are all beta blockers. The examples are diletazem, verapamil from calcium channel blockers, quinidine, procainamide and disopyramide from class 1A antiarrhythmics, and mexiletine from class first B phenytoin, and flecainide from class first C antiarrhythmics. So next we see the mechanism of these cardiac glycosides. So the normally sodium potassium pumps in the membrane of cells, that means cardiac myocytes, and this causes potassium ion influx and sodium ions in efflux. Cardiac glycosides inhibits this so that sodium cannot be extruded and intracellular sodium concentration therefore increases. That means this concentration arises. So and also a second membrane ion exchanger is responsible for the pumping of calcium ions out of the cell and sodium ions in 3Na by Ca, that means calcium, and this raise the intracellular sodium levels, inhibit this pump. So calcium ions are not extruded and they will also begin to build up the inside the cell, and they increase cytoplasmic calcium concentration, causes increased calcium uptake into the sarcoplasmic reticulum, and the raised calcium stores in the SR allow, that means sarcoplasmic reticulums allows for greater calcium release on stimulation. So the myocyte can achieve faster and more powerful contraction by crosses the bridge cycling, and binding of cardiac glycosides to NAK ATPase is slow, and also after binding intracellular calcium increases gradually, and thus delayed action of digitalis even on intravenous injection. And also the raised extracellular potassium decreases binding of cardiac glycoside to NAK ATPase, so increase toxicity of these drugs in the presence of hypokalemia, and FAB antibodies used to serve the toxicity of digitalis. So next we see the types of agents and their effects. So the types of agents and their effects of preload, that means cardiac filling pressure and afterload. So there is pressure overcome by the heart to pump blood into the circulation. So the first agent is calcium channel blockers, direct vasodilators. Examples are hydralazine and also prazosin. This prazosin is alpha 1 blocker, and the effect of preload is mainly decreases after the load. And the second agent is nitrates and diuretics, and the effect of preload is mainly decreases preload. And third agent is sodium nitroprusside and AC inhibitors and vasodilators, and the effect of preload is decreases preload and decreases pre and afterload. So the next we see the physiological changes in the chronic heart failure. There is blood pressure decreases in reflex sympathetic stimulation through the pressure sensitive baroreceptors. Pressure sensitive baroreceptors present on carotid sinus and aortic arc. In that, first the activation of beta 1 gives the increases cardiac output, and they gives increase in blood pressure. And the second one is activation of alpha receptor on vascular smooth muscles. They gives the increases TPR and it gives the increase in blood pressure. So, and also there is this blood pressure decrease renal blood flow gives the baroreceptor on juxtaglomerular cells of the kidney activated, and it gives the renin release, and it produces the AG2 activation, and it produces the vasoconstriction and aldosterone, that means sodium water retention release, and this increase in blood pressure. So the next mechanism is the angiotensinogen alpha 2 globular protein. This is produced by liver, and in presence of renin inhibitors and renin aspartic acid protease mainly in kidney forms angiotensin 1 decapeptide. This is bradykinin, and this angiotensin 1 decapeptide in presence of AC inhibitors, that means angiotensin converting enzyme zinc mactaloprotease forms angiotensin 2, that means octapeptide, and the bradykinin forms the inactive products, and this angiotensin 2 octapeptide at 2 antagonist produces the at 2 receptors. So this is the physiological changes in chronic heart failure. So